Okay, so now back to part 3 of the circulatory system. And in this, we're going to be talking about the vascular part of it. So it's a cardiovascular system. We talked about the cardiac portion, and now we'll move on to the vascular system. Vascular system are basically your blood vessels, and those are the pipes where the blood would be flowing. We have, different vessels that range from arteries to arterioles, which are smaller arteries. And then it moves on to capillaries, and that's where the exchange of gas happens. And then we have venules, where we'll start gathering all of the deoxygenated blood, and then we'll gather that blood into bigger veins. And then all that venous blood is going to be dumped into the right atrium. The thing that all of these blood vessels have in common would be the inner layer. The inner layer is a single layer of simple squamous epithelium, and that is known as the endothelial cells or the endothelium. And that is continuous with the endocardial layer. So the inner layer of the heart continues as the inner layer of these blood vessels. So this is a comparison of the different kinds of blood vessels. This is a large artery, and you'll find that each blood vessel is made out of, whether it's artery or vein, made out of 3 layers. There's the externa layer, or the tunica externa, that's made out of connective tissue. And then there's the tunica media, which is made out of smooth muscle fibers. And then the intima, or the internal layer, and that again is made out of your endothelial cells, which are your simple squamous. As you move on to arterioles, you see here that we have lost the connective tissue, and we basically have some smooth muscle fibers and the endothelium. As you move on to capillaries, we totally lose the smooth muscles, and we only have the flat endothelial layer. We'll gather that now deoxygenated blood into the smaller vein known as a venule. You'll start seeing that these layers are going to reappear until we get into these large veins where 3 layers reappear all over again. But there's a couple of major differences between this large vein and a large artery. First off, veins have valves, arteries do not. Okay, and valves prevent the backup of blood downward. So a lot of our veins have to carry blood against gravity. So think about the long veins, say in the lower limbs. Even the veins in the upper limbs, they still have to go against gravity in order to reach the heart. So you have, so the vein has a bunch of valves to prevent kind of the regurgitation of the blood downwards, and kind of help the blood reach the heart. You also see that the inside, or the diameter of the veins is much bigger than the diameter of the arteries. And that is because the amount of smooth muscle in the wall of arteries is much bigger. It's thicker than the smooth muscle fibers that are found in the veins. Okay. And that leads, both of them are able to constrict and dilate, but obviously the ability in the arteries is much bigger than that in the veins. Now this shows the difference between pressure in the systemic circulation as opposed to pressure inside of the pulmonary circulation. In the systemic circulation, the pressure is much higher, especially in the bigger arteries like the aorta, for example. And then as we branch off into the smaller arterioles, then capillaries, venules, and veins, the pressure goes way down. You see here that in some of the when we reach some of the veins, the pressure in the veins can reach almost 0. Okay, and we'll see how, now that the pressure is 0, that pretty much means that the blood isn't going to be going anywhere. We'll see how the veins overcome that. The pressure in the pulmonary circulation is significantly less. So you'll see here, even in the big pulmonary artery, the pressure is much less than comparing it to the pressure in the aorta, for example. And again, as we move further away from that bigger arteries, the blood pressure tends to decrease. But you see in the pulmonary circulation, it does not really reach that 0. It goes about, 3 or 4. So arteries are kind of, generally kind of view them as elastic tubes. So they have that thicker, muscle fibers that gives it the ability to constrict and dilate. It also has the external layer, has a lot of elastic fibers, and that elasticity gives it the ability to dilate, or the ability to kind of to what is known as compliance. When the ventricles contract all of that blood into the artery is kind of like a balloon. It's able to accommodate that blood, and then because of the elastic recoil, it could recoil back into its original shape. And that's because of that elastic tissue that's in there. Arteries have these radii, large radii, if you put them all together, and because of that, there is less resistance to the blood flow in the arteries as compared to other blood vessels. The arteries are your pressure reservoirs, meaning that they try to keep the pressure in order to keep the blood flowing in them. And we'll see how that occurs, kind of like in this image right here. So this part on the top, represents ventricular systole. And this right here is going to represent one of the valves. So we'll talk about, left ventricle and the aorta. So this represents the aortic valve. And as the ventricle contracts and blood is pushed into the aorta, you see how it's able to expand and accommodate that blood coming in. Now, during ventricular diastole, you see the aortic valve closes, and because of the elastic recoil, the aorta recoils back and pushes the blood forwards towards the smaller arterioles. Okay? And that is why, again, we consider the artery, or arteries in general, we consider them a reservoir for pressure. That elasticity kind of maintains pressure for a longer period of time to keep the blood flowing in them. And here you can see a change in blood pressure in the during a cardiac cycle. Okay, so during ventricular systole, the pressure in the aorta goes up, and then during ventricular diastole, we would you would imagine that that the pressure in the aorta goes down, which it does. Not only because the ventricle is no longer pushing blood, but because, again, even the blood that was already in there is being pushed forward in order to go through the rest of the circulation. So ventricular systole, pressure goes up in the blood vessels in the aorta, while during ventricular diastole, you'll find that the pressure in the aorta is going to gradually go down. Now, as we age, our blood pressure changes as well. Okay, so the upper number in a blood pressure is your systolic pressure, while the lower one is your diastolic blood pressure. A systolic blood pressure tends to increase as we age because of the development of atherosclerosis. So we're going to lose that compliance that we had before atherosclerosis kicked in. While at the same time, diastolic blood pressure tends to get low. It tends to decrease, and that's due to the loss of the elasticity and recoil. So you'll see here that systolic goes up, diastolic goes down, and that increases the difference between them, and that difference is known as your pulse pressure. So if you feel the pulse, or compare the pulse, say, of a 20-year-old, and compare that to an individual who has atherosclerosis, maybe in their 80s, the pulse that you'll feel in the 80-year-old is going to be a stronger pulse, which does not indicate a healthier heart. It actually indicates pretty much the opposite. It indicates that the systolic is higher due to atherosclerosis, the diastolic is lower due to loss of elasticity and recoil, and it manifests itself as a stronger pulse. So your pulse pressure, and that's what we were talking about, is the difference between your systolic and diastolic pressure. Okay, it is that pulse or throb that you feel when you feel the pulse, say, in the radial artery, for example. And the things that affect the magnitude of pulse pressure are the stroke volume, okay, the speed of ejection from the ventricle, and arterial compliance. So any decrease in arterial compliance, for example, in atherosclerosis, which leads to stiffening of the arteries, that could lead to changes in your pulse pressure. Now, these are, there's a YouTube video here and kind of goes over the different steps on how do we use a sphygmomanometer in order to record or to measure blood pressure. Okay, you're going to hear different sounds when you use a stethoscope or when you're using the sphygmomanometer, and those sounds collectively are known as Korsakoff sounds. I want you to watch the video and be able to, kind of learn on how to do that. You definitely want to know what the name of these sounds are and the kind of what they represent. So the very first sound that you're going to hear represents your systolic pressure, and then as you go down with your blood pressure, as you start to deflate that cuff, the sound is going to go down until pretty much it disappears, and you have kind of like this muffled sound that would represent your diastolic pressure. Now the arterioles, these are the blood vessels that follow the arteries. Okay, take the blood from the arteries and deliver them to the capillaries. And these are really responsible for determining how much blood gets to each organ. So your bigger arteries are like your aorta, for example, and then it moves on to smaller arterioles like the radial artery or the renal artery. And these arterioles are what really determine, those branches kind of really determine how much blood gets to each organ. Okay, so their importance is in that they are able to adjust how much blood goes to each organ. The diameter of these arterioles are determined by nervous system, by hormones, and even local metabolites, like how much oxygen is needed or how much waste products did that organ make. Okay, so if the organ is making too much waste products due to, say, exercise, then maybe we need to bring in more blood, and that leads to the dilation of these arterioles. Now, there's a relationship between the flow and pressure. We kind of already talked about this during the first part of this chapter. So we mentioned that if you increase resistance by vasoconstricting an arteriole, that is going to lead to an increase in pressure. Okay, but the amount of flow to that tissue is going to decrease. Okay, which makes sense. If you narrow the door, if you narrow the arteriole, that is going to lead to less blood reaching that organ. So in order to increase blood flow to an organ, you want to do one out of two things. Either you dilate the arterioles, okay, or you increase the overall blood pressure. And you could do that by maybe increasing the force of contraction by the heart. So that's going to increase the overall blood pressure, and that will push more blood into the organs. Now for flow regulation. So autoregulation means that how can each organ regulate the amount of blood that reaches it. Okay, that is what autoregulation means, where each individual organ has its kind of own regulatory system. And again, that really depends on, intrinsic factors. Okay, for example, metabolites. Okay, although autoregulation is still under the higher control of extrinsic, like the autonomic nervous system, but the individual organs do have kind of a say by the amount of the local metabolites as to how much blood it would need. And here you could say, you take a look at the response when it comes to local control. So during active hyperemia, that could be due to, think of skeletal muscles again that are now exercising, and there is a buildup of carbon dioxide and lactic acid in the muscles. So we have an increase in the metabolic activity of these organs. So there's increase of the metabolic products and relative hypoxia. So there's an increase of need of oxygen. And because of that, the blood vessels in that organ in the skeletal muscle are going to dilate, and that will increase the blood flow to that specific organ. That is known as active hyperemia. So we are locally increasing the amount of blood going to the organ, again known as hyperemia. Now, there's another way, okay, besides the metabolites, where we could auto-regulate the organs could auto-regulate their needs. So if there is a decrease in arterial pressure going to a specific organ, okay, let's say there is decrease in pressure to the whole body, and arterial pressure, say, to the kidneys have decreased. So the blood flow to the kidneys are now less. That means that there is less oxygen. There's going to be an accumulation of metabolites. Okay, that is going to lead to a reflex dilation of the arterioles in order to restore the blood flow back to normal. Okay, so it really all goes back to this relative hypoxia and the accumulation of metabolic byproducts. Now for the higher control from the autonomic nervous system, the sympathetic nervous system, using norepinephrine, okay, will lead to the stimulation of alpha receptors, alpha adrenergic receptors, and that leads to vasoconstriction. While epinephrine can also lead to the stimulation of beta 2 receptors, and that could lead to vasodilation. So you kind of want to think about the different needs of the body during exercise. So some blood vessels, for example, the ones going to the lungs and to the skeletal muscles, would have to dilate. Okay, so those organs would have these beta 2 receptors. While other organs, while we're exercising, are less important, like our digestive system. Okay, so we are going to shift the blood from the digestive system into the skeletal muscles. So your digestive system would have alpha receptors, okay, so that when we exercise, they are going to constrict and get less blood and shift that blood to these now dilated arteries that are found, again, in your skeletal muscles or in the lungs. So we have, these different actions because of the presence of these different receptors in different parts of the body. Now, the importance of the endothelial cells of our blood vessels, they're really important because healthy endothelial cells have a huge role in preventing clots from forming inside of the blood vessels. Okay, they secrete different chemicals. These chemicals are known as paracrine agents, okay, and those can lead to either vasoconstriction or vasodilation. For example, one of the most important is nitric oxide, and at baseline, nitric oxide is made by these endothelial cells, and it leads to vasodilation of blood vessels. This shows the functions of the endothelial cells. The ones that you kind of want to focus on would be that they are the physical lining, and just the fact that they are smooth, that prevents the formation of blood clots. They are also a barrier, okay, for keeping things in and preventing certain things from getting out of the vascular system. They secrete paracrine agents, like we already mentioned, prostacyclin and nitric oxide. They help what is known as angiogenesis, which is the growth of new capillaries, and they produce growth factors. So even if there's a damage to the endothelial lining, they make growth factors, and that can stimulate the growth of the repair process. Now moving on to capillaries, those receive blood from the arterioles. This is where exchange of gas happens, and then blood moves on to the venules. The capillaries, they're the smallest, and they're only made of that single layer of endothelial cells. If you put all the capillaries together, on average, we have about 25,000 miles of them. Okay, they are found in all of our tissues with the exception of the cornea. You need the cornea to be totally transparent so it has no blood vessels. Okay, and that again is where gas and nutrient exchange happens by diffusion. So you can see here the arterioles are going to bring in the oxygenated blood, and that has the oxygen and all a glucose and all of the needs of the tissue. And then we'll break up into these capillaries and capillary network. And again, exchange of gas happens, now becomes deoxygenated blood that has less oxygen but has the metabolic waste like carbon dioxide. And these are this is your venules, and that will take the blood down to the veins. This is a cross section of a capillary. So you see here it's made out of that very thin layer of simple squamous epithelium. We have some of these clefts, which are basically kind of like pores in between the cells. They're very narrow. This is the nucleus of the endothelial cells. You can see here one red blood cell. So, these are very tiny microscopic blood vessels. Now for the diffusion rate. The diffusion, into or out of the capillary depends on the difference in pressure. So you'll find here, this is a systemic capillary, and this right here represents a muscle cell. So the arterial end, this is the oxygenated blood coming in. Oxygen levels here is much higher. So oxygen is going to diffuse in this direction. So would glucose. Okay, and because there's a buildup of carbon dioxide in the muscle cells, the concentration of carbon dioxide here is much higher than it is over here in the capillary. So carbon dioxide is going to diffuse down its concentration gradient into the systemic capillary and then moves on to the venules. Fluid movement across capillaries is dependent on two different pressures. There's hydrostatic and colloid or osmotic pressure. These two pressures are going to come back when we talk about how the kidneys make urine. So these are two pressures you really want to understand. There are two pressures, hydrostatic, and that pressure pushes things or filters things out of the capillary. And the other pressure is osmotic pressure, and that pressure pulls things back into the capillary. So these two pressures work against each other. Hydrostatic pressure, again, filters things out of the capillary, while osmotic pressure would like to pull things back in. So we'll take them, one at a time. So hydrostatic pressure is the pressure that is exerted because of the presence of water. So as water flows inside of the capillaries, it exerts a pressure, and that pressure is known as hydrostatic pressure. So the higher the blood pressure, the higher the hydrostatic pressure, the more filtration that would occur. So patients that have high blood pressures would have higher than normal hydrostatic pressure, and that can lead to edema, which would be swelling. So that you would find that sometimes hypertensive patients would have swelling in the lower limbs, and that is because of the increase of hydrostatic pressure. While osmotic pressure, that is due to the pull of water by plasma proteins. Okay, so things that cannot, these bigger molecules that remain inside of the capillaries, for example, plasma proteins, these are the most important, those are going to be pulling water into the capillary. And that is why, plasma proteins are made by the liver. So any patient that has liver failure, they have low levels of plasma proteins. They can also have edema, swelling in the lower limbs, or ascites, which is accumulation of fluid in the abdomen because of the low osmotic pressure. Okay, so we'll see here that how do these forces that are collectively known as Starling forces, how do they act on the capillary? So this is the arterial end of the capillary, and this would represent the venous end of the capillary. On the arterial end, you'll find that the pressures or the pressure differences, those favor filtration. Okay, so filtration is going to happen at the arterial end of the capillary. While at the venous end of the capillary, the pressures are in favor of absorption. Okay, so you'll find that because of the osmotic pressure, absorption is going to occur on the venous end. And that's how we make interstitial fluid. So the arterial end of the capillary, because of the high hydrostatic pressure in it, it favors filtration, while on the venous end of the capillary, because it has a low hydrostatic pressure, osmotic pressure has not changed, so you'll see that they're the same on here, but this is going to favor pull of water in, or absorption of water back into the venous end. Now moving on to venules and veins, these are known as your blood reservoirs, okay? Most of the blood at any given time at rest is going to be in our venules and in the venous system. They are known as capacitance vessels. They are highly permeable, okay? And this is how white blood cells, for example, are able to migrate into when there's an area of inflammation or an area of infection. Your walls of the veins are much thinner than arteries are, and because of the less amount of smooth muscles and less amount of elastic tissue, they're more compliant. And that again, that's why they act as blood reservoirs. You'll see here at rest that in this blue end represents the venous circulation. You'll find that 60% of our blood resides in the venous end, while the remaining part are kind of like scattered, where your heart gets about 10% and the rest of the body gets the rest, kind of depending on the needs. But again, the majority of our blood would be in the veins and in the venules, and that's again why we consider veins blood reservoirs. Now, venous pressure, and this is kind of like the dilemma here, that by the time the blood reaches the veins, systemic pressure is very low. So if you guys remember this picture right here, we talked about how pressure, how pressure in the systemic veins gets to very low levels and even, can maybe almost zero levels. So how is it that now that we don't have any pressure pushing the blood through the veins, how is it that that blood can go against gravity and go back to the heart? So there are different things that are there to help. There's what is known as the respiratory pump. So just the fact that we're breathing kind of sucks the blood up towards these negative intrathoracic pressures. So as you inhale and exhale, okay, you're changing the pressure inside of your thoracic cavity, and that helps pull, kind of like a suction, pulling the blood up towards the thoracic cavity. Okay. We also have a muscular pump. As we walk around, the skeletal muscles are squeezing the veins and pushing the blood towards the heart. Remember, we have valves, so the push is going to be towards the heart. And smooth muscle fibers are also under sympathetic nervous system. So if we are under sympathetic control, so let's say during exercise, that is going to stimulate venous contraction. Okay, so they have smooth muscles, so we can venoconstrict. And that is also going to promote, push blood towards the heart, and that will increase your venous return. Here you can see what is known as the skeletal muscle pump. There is the vein, and these are your skeletal muscle fibers. And as we move or walk around, it'll squeeze the blood to go upwards towards the heart. And you see that the presence of these valves prevent blood from going in the opposite direction. As we age, though, these valves become incompetent and we start to develop varicosities and so on. But, that is how the skeletal muscle pump works. That's why if you have a job where you stand for long periods of time, you are losing that skeletal muscle pump. Okay, so just standing there without movement, no muscle contraction, that is going to lead to the pooling of blood in the lower limbs, and that increases the hydrostatic pressure, and that can lead to edema. So what you want to do is be walking around, okay, and that walk with the contraction of the skeletal muscles, that increases the venous return and prevents the blood from pooling in the venous system. Now, how do we kind of, relate the venous return and stroke volume. So there are different things that we could do to increase our venous return, and we already talked about those. So there is the inspiratory movement. So as we inhale, that suction, the negative intrathoracic pressure is going to suck blood up towards the heart. Increase the skeletal muscle pump, so movement. Increase in the sympathetic stimulation to the veins that leads to venoconstriction. And any increase in blood volume. All of these are going to increase the pressure in the veins. When you increase pressure in the veins, that'll push all of that blood to the heart, so that increases the venous return to the heart. You've increased the pressure in the atria, and that is going to increase your end diastolic volume in the ventricles. Okay, so you've stretched the ventricular muscles, and that is going to increase the force of contraction of the ventricles. So you basically increased your stroke volume. Okay, so as you increase your venous return, you're increasing your stroke volume and your cardiac output. It makes sense. The more blood that goes back to the heart, the more blood that will be pumped out of the heart. So increase in venous return increases your stroke volume and hence your cardiac output. Now, what happens if there is a decrease in blood volume? So let's say somebody has blood loss or hemorrhage, and that leads to, lower blood volumes. That is definitely going to decrease pressure in the veins, which will decrease your venous return and eventually decrease your stroke volume and decrease your cardiac output, and that's why your arterial blood pressure goes down. Okay, but again, it's all about how much blood reached the heart. So what does my venous return look like? And that will correspond to how much blood was pumped out of the heart. That is going to reflect changes in the cardiac output. In order to regulate that, we have what are known as arterial baroreceptors. Baroreceptors are receptors that pick up change in blood pressure. And we have some of them in the arch of the aorta. Those are known as the aortic arch baroreceptors. And we also have receptors found at the bifurcation of the common carotid artery, and those are known as the carotid sinus baroreceptors. So they're very strategically located, where we'll take a look at the blood pressure as soon as it comes into the aorta. We'll also take a look at the blood pressure before the blood reaches the brain. If arterial pressure goes up, so in cases, for example, if hypertension, that is going to stimulate those baroreceptors. There will be lots and lots of impulses from those baroreceptors to the cardiovascular center that is found in the medulla oblongata, and that means that we have high blood pressure. So we want to lower it down back to normal. So you're going to inhibit the heart by increasing the parasympathetic flow to the heart, and you want to decrease the sympathetic flow to the heart and to the blood vessels. Now, how does, an overall look at how the body can compensate for hypotension or hypovolemia, loss of blood due to severe hemorrhage. There is, when we hemorrhage, there's a overall decrease of arterial pressure that decreases the amount of impulses coming from the arterial baroreceptors. So we will inhibit the parasympathetic, but stimulate the sympathetic impulses to the heart. Now, both of those together are going to stimulate your heart rate. Okay. Also, we are going to increase the sympathetic impulses to the veins and to the arteries. When we increase the sympathetic impulses to the veins, that means we're increasing your venous return, which, we already know translates into a better cardiac output. And when you increase the stimulation to the arterioles, that's going to lead to vasoconstriction of those arteries, and that leads to an increase in peripheral resistance and increase in blood pressure. So all of these changes together act together in order to restore the blood pressure back to normal. And that concludes part 3. On to part 4.